Welcome back, focused learners. Let's jump right into this explainer. Today, we're tackling the lower extremity, specifically zooming in on the lower leg and ankle. When you really look at the anatomy here, it is a truly fascinating and incredibly complex biomechanical pulley system. Every single muscle, tendon, and insertion point works together in this delicate, balanced harmony just to keep us standing upright and moving forward. And when that balance is thrown off, well, we need to know exactly how to test it and find the culprit. So, let's get into it.
Okay, let's dive into our roadmap for today. We'll cover lower leg biomechanics, testing the inverters, testing the everters, isolating the plantar flexors, the popliteus stabilizer, and we'll wrap it all up with our anatomical data master tables.
Section 1. Lower leg biomechanics, the complex pulley system.
Section 2. Testing the inverters, the tibialis anterior and posterior.
So, when our lower leg pulley system breaks down, we start seeing some pretty significant postural faults, things like a drop foot or an awkward varus position. To fix these issues, we absolutely must isolate the specific muscular culprit during our exam. Let's start with the tibialis anterior. This is a crucial muscle for the medial lift and stabilization of your foot. To test it, have your patient either supine or sitting and just support their leg right above the ankle joint. You are going to ask them to perform dorsiflexion of the ankle and inversion of the foot. Then you apply pressure against the medial dorsal side, pushing them back toward plantar flexion and eversion. Now the absolutely crucial point here is step 3. They have to do this without extending their great toe. If that big toe shoots up, they're substituting with other muscles, and you aren't actually isolating the tibialis anterior at all.
So why does isolating this specific muscle matter clinically? Well, consider what happens when it becomes contracted. A contracture of the tibialis anterior literally pulls the foot into a calcaneovarus position. This means the ankle is persistently dorsiflexed while the foot is inverted. Just imagine trying to walk with your foot completely frozen in that awkward position. It completely wrecks normal weight bearing.
Next up, we test its deeper partner, the tibialis posterior. With the patient supine again, place their extremity in lateral rotation and support the leg just above the ankle. The test movement here is inversion of the foot, but this time with plantar flexion. That little addition of plantar flexion is exactly how we isolate this deeper muscle from the tibialis anterior we were just looking at. Apply your pressure against the medial side and plantar surface, pushing back toward dorsiflexion and eversion.
Now, what's really interesting here is how weakness in this specific muscle alters walking. If the tibialis posterior is weak, it decreases support for the longitudinal arch, which leads to pronation. But it also interferes with the patient's ability to rise up on their toes. This inability to transfer weight normally actually inclines them toward a fascinating gait abnormality known as a gastrocnemius limp.
Section 3. Testing the everters, the peroneus longus and brevis.
Okay, now we're shifting our focus to the lateral stabilizers of the leg. These act as the direct functional opposites to the medial inverters we just covered. For the peroneal muscle test, position the patient supine with medial rotation or sideline, support above the ankle, and ask them to perform eversion of the foot with plantar flexion. You'll apply your pressure against the lateral border and sole of the foot, pushing toward inversion and dorsiflexion. And here's a great functional note to keep in your mind's eye. During normal weight bearing, the strong pull of the peroneus longus actually depresses the first metatarsal head firmly into the floor. It's a key part of your stance.
If these everters are weak, you're going to see a very specific set of clinical signs. The patient will obviously have decreased strength in eversion and plantar flexion, which naturally allows the foot to fall into a varus position. It also lessens their ability to rise on their toes. But practically speaking, weak everters drastically decrease the overall lateral stability of the ankle. This leaves the patient highly vulnerable to lateral ankle sprains, and we've all seen how stubborn those can be.
Section 4. Isolating the plantar flexors, gastrocnemius, soleus, and plantaris.
And this brilliantly illustrates how we actually tell these powerhouse calf muscles apart during a manual exam. We use the concept of mechanical disadvantage. To test the gastrocnemius, the knee must be fully extended. But to isolate the soleus, which, remember, does not cross the knee joint, we flex the knee to at least 90 degrees. Doing this puts the two-joint gastrocnemius on slack, effectively neutralizing it so we can feel the true isolated strength of the soleus. It's an elegant little mechanical trick.
To test the gastrocnemius, have the patient lie prone with their knee extended and their foot hanging off the edge of the table. You just use the weight of their leg for fixation. Ask them to plantar flex by actively pulling their heel upward, while you apply pressure against both the forefoot and the calcaneus. Now listen up, here's a clinical insider tip. Watch closely for visual substitution. If the heel pushes up secondarily to the anterior part of the foot flexing, they might be cheating with their toe flexors, tibialis posterior, or peroneals. You really have to watch them like a hawk. So, what happens if the gastroc is chronically short? Well, it restricts ankle dorsiflexion when the knee is extended, and it restricts knee extension when the ankle is dorsiflexed. To compensate for this during the stance phase of walking, the person will physically toe out. And amazingly, or maybe not so amazingly, this shortness develops constantly in individuals who frequently wear high-heeled shoes. It literally reshapes their baseline anatomy.
Moving right along to the soleus test. The patient remains prone, but you will flex their knee to at least 90 degrees. Support the leg just above the ankle and ask for pure plantar flexion without any inversion or eversion. You apply pressure against the calcaneus, pulling the heel caudally. Pay close attention here. If the patient tries to extend their knee during this test, it's a dead giveaway. They know their soleus is weak and they are instinctively trying to recruit their gastrocnemius to bail them out.
You see, the soleus is absolutely critical for our standing posture. Weakness here results in an anterior displacement of body weight. Because the soleus anchors the tibia to the heel, its primary, all-day job in a standing position is to pull backward on the lower leg. Without it doing its job, we would literally just fall forward off our normal plumb line. It keeps us upright.
Section 5. The popliteus stabilizer, the unlocking muscle of the knee.
Now, let's move slightly up the leg. The mechanics of the popliteus are incredibly neat because it essentially lives a dual life. When your foot is swinging in the air, meaning non-weight-bearing, it medially rotates the tibia on the femur to flex the knee. But when your foot is planted firmly on the ground during weight-bearing, the origin and insertion effectively swap roles. It laterally rotates the femur on the fixed tibia to initiate knee flexion. It's like a mechanical switch.
To test this highly specialized muscle, have the patient sitting with their knee flexed at a right angle and the leg laterally rotated. You don't even need fixation for this one. The movement is just medial rotation of the tibia on the femur. What's distinct here is that you seldom apply actual resistance or pressure. We don't really grade the popliteus like the big power muscles. We just perform this quick check to make sure the muscle is successfully firing and active.
Section 6. Anatomical Data Master Tables Origin, Insertion, Action, and Nerve. Let's move to the data and see how this all builds together.
To truly master clinical anatomy, you've got to have the hard data right at your fingertips. Looking at our inverters and everters, notice the tibialis posterior is innervated by the tibial nerve, L4, 5, and S1. Contrast that with its functional opposites, the peroneus longus and brevis. Those are supplied by the superficial peroneal nerve, L4, 5, and S1. It's brilliant. We have completely different nerve supplies orchestrating perfectly balanced opposing actions. Now for our plantar flexors. The gastrocnemius, soleus, and plantaris all share an insertion onto the posterior surface of the calcaneus, pulling as a united front. However, look at their origins. The gastrocnemius and plantaris originate way up on the femur, crossing the knee joint, while the soleus originates firmly below the knee on the fibula and tibia. Despite these different origins, all three are driven by the tibial nerve.
And finally, our knee stabilizer, the popliteus. Originating at the lateral condyle of the femur and inserting on the posterior tibia, it's supplied by the tibial nerve, L4, 5, and S1. And that wraps up our master reference data. That is exactly what you need for complete anatomical mastery of this region. Before we wrap up, I want to leave you with this provocative thought. Think about this. If merely wearing a high-heeled shoe can physically shorten a powerful calf muscle like the gastrocnemius over time, how might an undiagnosed weakness in a tiny foot inverter cascade into major postural faults all the way up your kinetic chain? The body is deeply, deeply interconnected, and mastering these lower leg fundamentals is really just the beginning. Thank you so much for bringing your focus today. I hope this explainer leaves you eager to trace these fascinating biomechanical connections even further in your future learning. See you next time.